I really wanted to do this from the start, and that was to bring her home. My two daughters have always been reluctant to do that, for not because they don't love their mom, because they love their dad. And this is a different arrangement. But our options, as they developed, was to bring her home. Well, that decision to bring her home and what was required, the hurdles we encountered, for example, ambulance service. You think you can get ambulance service. You can't get ambulance service. There's emergency ambulance service, and then there's non-emergency, and you may be able to get it, or you may not be able to get it. And there's going to be a huge cost in getting it. All of these things. And then we had to go through the process of who's going to provide this home care. We had to rent a hospital bed. Supplies and I mean, it's just the list is endless. But I like challenges and like being busy. So from that perspective, I had a full plate, and I worked at it every day. So we got the hospital bed, we got the ambulance service. I called some friends. Friends make life better. I called some friends who I had known who had been through this, whose spouses had Alzheimer's and they had home care. So I called them to get recommendations, to talk with them. Came up with two different groups, invited them here to the house, let them see the house and see where Nadine was going to be, and let them tell me my story, their story, as to what they would do and how they would do it. And out of that, it was really, I use the term interesting a lot. It's interesting to me. It may not be interesting to everybody else, but it's interesting to me. This is an interesting part of the story. The two different groups that I interviewed were so different. One group, and they were both great. Now, how do you make that sort of decision? But one group, if you've seen the movie Help or read the book Help, one group was essentially out of that time period. African-American women who would provide loving and good care. The other is headed up by a nurse. She's not, and was a wound nurse for 31 years. And she still does some nursing, but she had to put her father-in-law had to have home care. And it was a disaster. The home care people stole from her father-in-law, and just all sorts of bad things happened. So Lindy, if I can use her name, I'm sure she won't mind that. I haven't asked her, but I'm going to take that advantage of that anyway. She retired or quit full-time nursing to establish her own home care program because she wanted people to have fair, good, caring home care. And so she established Integrity Senior Care. And that story, as much as anything, plus her bringing her professional background, even though in this capacity she can't be a nurse, technically she'll always be a nurse. She understands, she sees. So we employed her group, and she's taking care of the workers, and she trains the workers, and she does it all for the right reasons. And again, a part of the story, which is perhaps, I don't know, it's really unique. There aren't many things that are really unique. But as it turns out, she is not only a nurse, a true caregiver. She cannot stand to be idle. So she said, since I'm here, why don't I cook? Why don't I clean the house? Well, this was like manna from heaven. This was a gift. So now we have been in this stage for a few weeks now, and as Christine has heard me say before, I'm sure, to me, life is a set of rhythms. We get into rhythms about how we get up, how we dress, even how we brush our teeth, whatever. Well, in these changes, your rhythms, you lose your rhythms. And you have to establish a whole new set of rhythm wherever you are. And so we're in that process. We're trying to find the right rhythm that will adjust and make it all work. Now that's the logistical side of it: the hospital bed, the ambulances, the care people. But then there's the financial
so Gerald,
side.
before you move on to the financials,
Sure.
I'm curious. I think you have, if I remember, now I'm trying to remember, you also have some volunteers that you have participating, or you
Yes.
did at least, because you built a broader base than just paid people.
Yes.
For you and Nadine and the family. And so I didn't want you to leave that piece out, because that was another interweaving that you had to do. That's not about the finances, but boy, it takes time to do this.
That's an important part of the story, Teepa. So I'm glad you brought that up. And this is a part of finding the rhythm as to what works. Originally, we set it up where the caregivers, and if I might stop and just interject another point at this, and Christine and I have talked about this particular topic, the difference between a caregiver and a care partner. And so I use the terms very differently. They're two different worlds. The caregiver is a paid, trained professional who works, and they may be care partners as well. They're caring people, but they're caregivers, trained for the job, paid for the job. They work a shift and they go home. A care partner, on the other hand, whether it's a spouse or an uncle or a cousin or just a friend, they're not trained, they're not paid, they don't work a shift, they're on duty 24 hours a day. And the needs of care partners are so different, while they overlap, from the needs of caregivers. So I use those terms differently for very specific reasons. And I think it gets confusing when we try to say this is a program for caregivers. Are we talking about caregivers or care partners? They're just two different worlds. Well, initially, we tried to combine these two. And we set up the caregivers to come for 2 hours at breakfast and 2 hours at lunch and 2 hours at dinner to clean and feed. And in between, another one of these friends who make life better volunteered to set up a volunteer program to help. And initially, the idea was when we live in a multi-generational house. It's me and my daughter and her daughter, our 9-year-old granddaughter. And the volunteer program was initially set up where we would have breakfast, lunch, and dinner. And then when I could not be here and my daughter could not be here, then all I have to do is let the volunteer who set up the volunteer program know, and they would provide volunteers. And these are folks that we know in the community, and it's just been overwhelming. When we started it, I asked for just, I think, 2 hours in the first week or so. And I got a text from my friend and says, don't be stingy about asking for volunteers. People want to volunteer or want to help. So that's how it started. And that was such a good thing. That was just such a loving, caring friend thing. Well, we quickly found out that level of caregiving need was not sufficient. And so I made the decision to not dismantle, but to delay the volunteer part of it. Just keep that in place, but suspend it and extend the caregiver part of it. And we've done that. And as we do that, that's a good segue, Teepa, to the cost. Because once you expand to caregivers rather than volunteer care partner types, that's another different world also. Well, we made that decision. And I'll be as brief as I can about the cost part of it, but it's a complex, important part. And I say it's complex because there's tension between wanting to provide the best care you can and the realities of the cost. And the policy structure really forces you to make some awful choices. Now, let me explain those choices for the folks who are listening to us. I'm really trying to talk to all those folks out there who just want to learn and hear this story. Starting out here at home, and in fact, going back to 2012, and when we moved to a caregiver who came during the daytime, and there's an interesting, again, that word story there, Julia Arana from Guatemala, but she's been in this country for 30 years. She became the caregiver, but she and Nadine developed a relationship family. They love each other, and still there's that special connection. So she came during the day, and that was, of course, a cost, but it was a minimal cost and really worth the cost. That wasn't any problem. But then as we tried to move to 24-hour coverage, of course, the cost is much different. And then we went to institutional care. And excuse me, I have my phone on. I don't want that on. Excuse me, folks. I didn't turn my cell phone off. And I always tell my students to turn their cell phones off. So I'm not following my own advice. Teepa, turn your cell phone off. And you too, Christine. So there came the point when we, for all, I think, for all the right reasons, we made the decision to move to institutional care and found the right facility. And institutional care, the first thing you learn is not inexpensive. The cost at this particular place was $7,600 a month. Now that's $80-some thousand a year. I'm a retired professor. Retiree income for professors, not great. I'm not complaining. It's fine. It's good. But there's no help at all for that.
But that would be more. Was that as much as you made when you were a professor for quite a while? Not like top professor, top dog, but when you were in the university system, how long did you have to work there to get $80,000 a year?
About 30 years.
So in 1 year, you're already at top salary. And,
that's right.
And it feels like for a bed and some support and laundry.
Yeah, and
most of us, expensive apartment.
Most of us struggle to make our car payments $300 a month. Well, here's almost $8,000 a month. From where does this come? Well, I did make some good decisions along the way, and one is to buy long-term care insurance. And let me just stop there for a minute. I would thank all of your viewers who are going through this journey, particularly the younger ones. You need to do this before you're 65, because after 65, it's a different financial world. But long-term care insurance is a wonderful thing. our long-term care insurance provides $5,590 a month. That's $6,000. So that makes that $7,800 down to $1,600 a month, and that's 2 car payments, maybe, or 3 car payments, or whatever. So that's doable. And then for other reasons, we made a change of places for Nadine. And the second facility, better, and let me just mention, facilities can look good, and you walk in, it's like entering a luxury hotel, marble and flowers and ferns. But the only thing that's important in an institution is that frontline caregiver. And if that frontline caregiver is not a caring person, first of all, caring for dementia patients is the hardest job in the world. I don't know anything that's harder. You can care for a broken leg, a patient, or a heart patient, and you pretty much know what your world's like. Caring for dementia patients, you don't know from minute to minute, much less from day to day or week to week what it's like. And they're underpaid. And they're trained, the state requires training, but the training is how to feed and how to clean. And it really doesn't deal with relationships, which Alzheimer's, dementia is all about relationships. It doesn't matter what you do. It's how you feel. It's how you relate. And so we were in one situation, a great facility, but understaffed and not trained. And so we found another place where, well, the first place didn't have a on-floor administrator, director, manager. So the folks just sort of did. The place we moved to had an on-floor caring nurse type who managed all the CNAs, the caregivers, and trained them, tried to train them daily on how to not just feed and clothe, but how to really make a difference in the life of these people. And Christine and I visited that, and that is a connection you folks have made because of their interest in Teepa snow. And so that has been good. Well, we made that change. Then we get the notice we had to do something else. Well, the second place was actually $5,500, which was even much better. That reduced our cost to $500 a month. And then we had to make the decision to bring Nadine home. Home care cost is over $12,000 a month. And that's just the caregiver cost. That's not equipment, that's not food, that's not all the other things, just the caregiver cost. Now you think about $12,000 a month. That's, for me, that's a lot of money. It's unsustainable. And the options, here are the options. You can get Medicaid care, but to get Medicaid care, you have to go broke. You have to divest yourself of everything you own. You have to be broke. The other support is Medicare. Medicare will support 100% if you're near death, you're dying. So here's my choices: go broke or to hope Nadine's dying. That's just beyond ability to comprehend. It
literally feels wrong that to have someone in your home and to get the care for that someone in their home, you either have to be destitute and then hope that whoever does Medicaid reimbursement has enough staff and has the skilled staff that they would be able to deliver the care at home, because Medicaid providers don't get reimbursed as much as other providers. So it means that their ability to prepare those providers to give care and support those providers giving care is actually less. And then if you're hoping that someone's dying, well, you're not. I mean, that's not what anybody's hoping. But until somebody gets to that point, things aren't covered unless you go into the hospital. And then you can get it covered. It's like, well, but who wants somebody to get sick and go to the hospital? The whole point of do this at home. So, yeah.
Interesting point. Interesting point again. I keep using that word interesting. It's a relevant point. Let me use another term. We tried the hospital route to get Nadine admitted to the hospital, and then they have a senior care floor, and that would provide some time for us to make this transition. But with COVID, that was blocked. So just every avenue just seemed to be difficult. So we've got these two options: be broke or die, and we're in that middle ground where we don't qualify for each of those. We of course still have our long-term care, and that will provide not even half the cost. And so for some period of time, this is what we're going to do. But our next step in terms of a cost, and we've already started some negotiations with some discussions with a facility here in Auburn, not 50 miles away, which is also will be good. But they had a COVID case. They've been locked down, not admitting anyone. And frankly, I don't want Nadine to move back to a facility until we get a real understanding of where she is. Right now, I don't know how much of her condition is physiological, how much is Alzheimer's, how much is medication, and how much is environment. And it's all of that, but I need a better feel of what part is playing what part before we make
another move. Yeah.
But that has to be the solution. We have to go to some institutional care to just cut costs where we can. Yeah. I can't sustain it. The current is just unsustainable. We are now. Each of us, Nadine and I, had some savings. 401s and RAs, IRAs, whatever they're called.
Yeah.
But that's not what we're using.
No. Yeah.
And that's fine. I'm glad we have it. But that's not sustainable either.
Yeah, that you didn't have them for that.
Hi, I'm Teepa Snow, and you just found our YouTube channel and watched one of our videos. I'm the owner and founder of Positive Approach to Care. Thanks for watching. And if you liked, if you have a comment about, or you would, please share it with people you know. Oh, and if you haven't yet done it, consider subscribing. We'll let you know when the next new video comes out. And you might want to visit our website, www.teepasnow.com, where you'll find other resources as well. See you there.